Recording. So welcome back for our second half of the day. Thank you all for rejoining our call. Next, we'll be having a lecture by Dr. Ponson. So Dr. Ponson is the medical director of the Children's Day Hospital at Yale New Haven Children's Hospital, which serves children ages 5 to 12, and medical director of outpatient clinical services at the Yale Child Study Center. He was the past medical director for Children's Psychiatric Inpatient Services and Child Psychiatric Consultation Services to the Pediatric Emergency Department. He is an assistant professor of clinical psychiatry with the Yale School of Medicine. And today he will be giving us a lecture on children, developmental, and disabilities.
Hello, everybody. Thanks for being here. So first rule of thumb, when you give a lecture, try to have your title slide like correctly edited. So when I sent to Alexandra, I think I had developmental needs instead of development. So it should be development, children, development, and disabilities. So just to start, since we are, this is a student group, just to give you a sense of my background and where I got to where I am, because I think that just like to share that. So the reason for my atypical name is my family's from France. I was born here. We went back to France. I came back when I was very young, and then grew up in the States, college, etc. And then after college, I worked in New York City as a recruiter, using my language skills to recruit people for international organizations, primarily French or American companies or governmental organizations dealing with France. Probably sounds more exciting than it is, but so I did that for a little bit. And the part I liked about the job was actually interacting with people more than the business end. And so then I went back to med school. I hadn't done any pre-med. So I went back and did some part-time pre-med. Then I did this program where you kind of save a year by not having to apply to med school. As long as you can get some decent grades, you're accepted to the med school. So that was Temple in Philadelphia. And then did my residency in adult psychiatry. And I don't know what my thinking was at the time for doing a child psych rotation. I just don't remember my thinking, because I was already fair older. I had 3 young kids, but part of it was, well, what's the worst that can happen? I do a child psych rotation, residency, and then I can use that information for my help my kids. But then sort of the rest is history, and I've been in this field for a long time. And what I most like about child psychiatry is just a lot of team aspects to this. It's really a world where you're wrapped around a child, teachers, parents, clinicians, really having to work together. So that's sort of the background. And what I was going to talk today, and I think this is a great topic because kids with the whole issue of ableism and really paying the kids with disabilities is an important aspect of what we do in child psychiatry, thinking about making kids as adaptive, as capable within their own individual capacities, and bringing them up to be able to function socially, vocationally, within their families, in multiple realms. So maybe we could do the next slide, Alexandra. Thank you for doing that. So I put this slide up just, I think in terms of, we're already aware of some of the historical backgrounds, but essentially we were a very messy field in terms of what to do with children. But obviously kids have been around a long time, and managing kid behavior and thinking of kids and intellectual disabilities has been something from time immemorial. As many of you know, the treatment of children with disabilities was pretty horrendous. Folks end up in institutions, sterilization campaigns, and it's only really through the course of this century, or putting folks with intellectual disabilities with severely mentally ill individuals. So it's only through this century that things have gotten better and certainly more community focused for integrating people into the community than it had been for both folks with mental illness or intellectual disabilities or both. And if we could do the next slide, Alexandra. And the terms change over the years. it would be incredibly a poor form to say imbecile. I don't know if intellectual disability will then become, the words have meaning, but then the words chase sort of the inherent biases that people have, whether those are racial, economic, intellectual biases. So then our biases catch up, and then we try to move the language forward. But I do think that it is important to do that. So child psychiatry really, just to give you a bit of the background, really formed in the late 19th century. Juvenile courts, some forward-thinking individuals that were concerned about juvenile delinquency in Chicago. Eventually, a juvenile court type system was formed in 1909 and eventually consisted of a social medical director, psychologist, social worker, and that model that eventually formed that tried to look at the whole child really became the model for child guidance clinics. So that combination of caretaking was a model for child guidance, a social worker with the families, psychologists doing testing. We don't quite do it this way nowadays, but those were the beginning years. And then let's do the next slide. So that's actually the court. And then we had, I don't want to spend too much time on diagnoses, but basically just the historical legacy of diagnoses was essentially people had very different ways of doing different things across the country. So you had hospital systems doing one thing, it was very regional, and DSM was sort of an attempt to try to become more cohesive. And we had DSM 1, 2, 3, and 3 was the first one that really was a bit more scientifically based. Another big thing that happened is that during World War II, when people in the draft, discovered that the folks that got either discharged from the military, got wounded, had problems in the military, were the same kind of folks that had problems when they were younger children. So kind of this focus on development and children and what happens to them became important. And Alexandra, if we could have the next slide. This is just to add that, there are parallel processes. Here, Frantz Fanon is a very well-known psychiatrist who became a political advocate, and he wrote about essentially Black alienation in terms of discussions around what it meant to be Black in a white culture and society, and mental illness and the categorizations of mental illness related to that. Some beginnings of the idea that paranoid stance at times by Black patients was a rational one. But there was a lot of debate at the time around. Well, let's move on from that. I just wanted to mention that there are all strands here. So a day in the life of. So basically, what I do in my day, I think child psychiatrists really have a lot of variety to their day. So again, taking the opportunity, since this is a psychiatric interest group, and then I'll get into more specific working with children with intellectual disabilities or other disabilities. So the child psychiatrist ranges from those that do psychotherapy alone primarily, psychotherapy and medication management in the community, private practice type stuff, to psychiatrists that are often part of a clinic in which they have some administrative responsibilities as medical directors. Treatment plans have to be signed off by a medical professional. So we sign off on treatment plans for all the kids. In my role, one of my jobs is to sign off on treatment plans. Every 90 days, we talk about all the kids in our outpatient clinic. There are other psychiatrists that do that, so I'm not the only one. We have about 600 kids in the clinic. So every 90 days, sign off. And then there are those that are more academically inclined and do research, of course. But ultimately, we're all involved in assessment, evaluations, and working with systems for the betterment of a child. So Alexandra, let's go on to the next slide to see what that brings. Oh, this is just a slide again to get into the topic of what children need and what children experience. So the main modalities are, individual therapy, group therapy. It's the case for adults. It's no different for children, essentially. So it's just to make that point. In my day hospital, yeah, that's fine. In my day hospital, the kids are 6 to 12. It's very much a verbally based program. So you have to have verbal skills for that particular group and be able to be in a group for 3 hours. And we obviously make it kid friendly. But that's what we do there. So essentially, in terms of children and development, there's several things that we think about. There's the in utero environment, and which is becoming increasingly important in the field. What the external environment is to the child, both in terms of like family strain, maternal distress, interpersonal violence, the effect on the child in utero, to budding genetic findings when a child's already in utero. But the field of infant psychiatry or in utero psychiatry is emerging. I mean, it's mostly in researchers. We're not doing kind of therapy with in utero, but parent maternal wellness is incredibly important, and paternal wellness. I mean, historically, mothers were easily blamed for behaviors, and so it's a fine line of that as well. Then the things that we look at in children, essentially these, I just wrote the main areas of development that are important and where they can go awry. So one is temperament. We're all born with certain temperaments and certain ways of doing things. Our reactivity to the world, our baseline mood, our attention capacities. There's ranges of that, and we're all inherently born within a certain range of that. And some of these, have greater or lesser degrees in terms of cultural factors, but they're pretty consistently found across cultures. Kids' health, kids' language, cognition, and that's where the intellectual issues come in. One's emotional regulation capacity, socialization with peers, and then kind of our moral socialization. And then all of these issues are embedded within a larger matrix of the individual, the family, the school, the community, neighborhood, environmental, socioeconomic factors, racial, cultural, gender topics, sort of both in terms of kind of wider community, but also in kind of intersectional factors as well. And let's see what the next slide brings. Yeah, just to point out that it's kind of what I was saying before. Child is kind of at the center of a larger matrix, and it's impossible to think of a child as without that. I think in adult psychiatry, we know this, but it tends to get more abstract for us. Like we have a patient in front of us with a certain mood and a certain issue, from psychotic, manic to anxiety, mood, but and we know that they live within a larger social, familial context, but we tend to work a little bit more with that individual abstracted out of that context. Whereas with the child, it's very hard to do that, meaning that you're not going to get anywhere just obviously working with just the child. Now, there are some child psychoanalysts, there's not many around that still do this, but who really thought that you should only work with the child, never communicate with the parent, and that's it, and do just the therapy that way. But that's rare nowadays, and most child psychiatrists are going to speak to a school. They're going to speak to the therapist if they're not doing the therapy. They're going to be speaking to the parents, and they're going to speak, might even going to bring the grandparent, like we'll bring in the grandparents, we'll bring in the aunts and uncles. Sometimes we've had meetings in the children's day hospital that literally have 11 people, like 2 sets of grandparents, the stepmother, stepfather, mother, father, and that is a very important piece of discovering a child. So let's go on to the next slide. Yeah, so then we have psychosocial assessment, which we do. So let's go into the next slide. So essentially, okay, now this is starting to get about finding, quote, problems or difficulties. And the best way, there's always the topic of are diagnoses labeling. And it's an interesting piece, the diagnostic and the labeling, from the kind of Thomas Salt's perspective, that these are all, I guess, mostly pejorative, and a diagnosis is a label and a categorization, to, which has some accuracy to it. to the view by patients of like, no, this is what I own. This is what I have. I am autistic. This is what I am. And I'm proud to be it. And it's helpful for me to know what my quote label is or diagnosis is. So I think people and clinicians have a range of thinking about the topic of diagnosis and assessment. But in the end, ultimately, and I think in our outpatient clinic, we tend to not get too caught up on diagnosis. I mean, diagnosis is important, and it's particularly important in two areas. So one is intellectual disability, which to receive services has to be an IQ below 70 and has to be adaptive behavior below a score of 70. And essentially that's, 2 standard deviations below, and that will allow you to access services in Connecticut. And, I'm not sure how much you got into the other lectures, but states vary in terms of how much support families get. And I think families are drastically undersupported in the area of intellectual disability and services usually. Certainly in Connecticut, a mental health treatment is more robustly funded than it is and then for folks with developmental disabilities, especially as children. But essentially what we think of in terms of assessment and diagnosis is a kid meeting what would be, I guess you could say, typical expectations for a certain age, right? So the way it works is that you'll see your pediatrician, and your pediatrician will monitor for milestones. And from that, if there are concerns, a pediatrician can refer someone to what's called birth to 3 in Connecticut. 0 to 3 is the more common umbrella term. And birth to 3 is a service that allows you to assess kids' function across multiple domains. So evidence-based instruments are used to assess a child's social function, behavioral function, cognitive function, intellectual function, and where they fit on, quote, norms, what are normed samples. And if a child is found to have concerns in regard to those norm samples, then services are offered. And this is a kind of anyone will be able to access that service. Some kids have an evaluation for birth to 3, and that could be, let's say, a kid with articulation difficulties, assess the speech, assess other factors, and it's a mild articulation difficulty. You don't need birth to 3 services, as an example, or just one thing I think. So sometimes it's just an evaluation and no services are provided because it's not needed, or an evaluation and treatment. A child then after 3, if this happens, will go into, and by the way, I'm saving questions for the end because Alexandra, you said save time for the end. I mean, I'm happy to take questions in between, by the way, if you want to monitor the chat, just so you know. Don't necessarily need to hear myself talk the whole time either. But early childhood assessment teams, ECAT teams, I'm not sure if what their name is across the nation, if they're called that too, are the 3 to 5 range. So that's either transitioning from birth to 3 to ECAT, or to someone's identified after 3 as potentially needing services. And these are kind of embedded within the school system. So the way it works is that schools are obligated to, it's called child find. And so child find, schools are obligated to both help assess children who may have potential needs, but also find those children who have potential needs. So it's not, the onus is not on the family to say, I have a problem, I need help, but it's really the school should be attuned to kids in the community and what they may need, or kids usually within their school system or school district. Like the problem shouldn't be on the onus of the parent to identify that there's an issue at school. Often it is, and schools with fewer resources sometimes can have kids that can be way behind and it's just atrociously unfound, so to speak. It's sort of, I've worked with kids who might be 11 years old, can't read at all, and somehow they're in 6th grade with no one really having paid attention to this before. That is not a typical situation, but that certainly does happen. or a child without as many, so drastic a need who was basically not found by the school to have issues earlier. So if a child is identified as having any kind of problem, and then they will be labeled as having a developmental delay, whatever that particular problem might be. And then when they hit about 5 or 6, that is when they will have a reevaluation to try to determine what delay remains, if any, and then what categorization they should have under school special education and related services. So essentially, the background for schools is that kids with severe problems just weren't allowed to be in schools, essentially. I mean, a school could say, we can't manage your child, so sorry, essentially. To kids with autism, kids with severe behavioral problems, kids with severe intellectual disabilities or intellectual disabilities that weren't felt to be manageable by the school or available to learn in the school could be just essentially booted out of school, essentially. And so families sued. I think the first lawsuits were I'm forgetting 50s or 60s, and essentially case law emerged that a child deserves an education within the school regardless of their abilities, and the schools must provide for that. And there's kind of various educational acts that eventually evolved into the Individuals with Disabilities Education Act, which is what we have now, with several iterations, along with the American Disabilities Civil Rights Act of the mid 70s, where folks with disabilities were allowed accommodations within work and school environments. So the difference being, this is a quick digression for those of you who may not know, work is supposed to provide accommodations. So if I have a wheelchair and if I'm a child that has a wheelchair and I can't use the stairs, then I can use the elevator that adults use and staff use and no other kid uses. That's an accommodation, just accommodating my ability to access my education. Now, special education and related services, special education is you're actually giving service to help the child. So reading, speech and language. So that's how that essentially works. So in special education law, you have essentially 23 categories in which a child can receive special education services: autism, intellectual disability, ADHD, other health impaired ADHD, emotional disturbance, which actually is a word that's going to change soon. But anyway, emotional disturbance, speech and language. Those are the most common that a child psychiatrist would interact with: the autism, intellectual disability, speech and language, emotional disturbance, and other health impaired ADHD. So when a child is in a school, if they're not discovered early, like I just mentioned, the school will do, or they're discovered later, the school is obligated to do evaluations to determine what a child's needs are. And those will involve cognitive assessments, emotional behavioral assessments, speech and language assessments, assessments for autism to a degree, and then determinations are made, academic assessments, of course, and then determination is made whether a child needs special education services. And then they have one of those labels I mentioned. There's like 23, and then one of those. So it could be, hearing impaired is another one, for example. So that's where that piece of it works. And then in terms of other assessments outside of the school system, you have psychological assessments, neuropsychological assessments, where you also will do cognitive testing, academic testing, and other aspects of brain function to determine how someone does or is doing. So let me just look at the time. I think we're pretty good. Yeah. So maybe you could go on to the next slide. And that's just to say that that this slide just lists out that we have school-based services, which are very important in the life of children with disabilities, and then community-based services. Schools are legally bound to provide services to children in school who need them. So how does that look? Well, first of all, a kid with an intellectual, who has an intellectual disability. By the way, in terms of our language that we tend to use, we tend to say, um, a child with ADHD, a child with an intellectual disability. We don't say an intellectually disabled child or an ADHD kid or an autistic kid. We tend to not fuse the label in the person. But any event, a child who, so the case law is such that now children are supposed to be educated as much as possible with their peers. And today what happens is that sometimes it's the opposite need that occurs, like a family feels or school feels that a child can't be serviced within the school and they need another placement. And so some families, from the family perspective, want their child to be really be in the school no matter what, even if the school probably can't legitimately service them. And other families want their child out of the school into a specialized school that can better help a child with their specific needs. A situation like that might be a child, let's say, whether they have an intellectual disability or not, who is severely agitated and behaviorally discontrolled in a school environment, and needs more support to manage that, because it disrupts the class. They have to leave the classroom. The classroom has to be emptied. They're just not getting their education with the amount of supports that a public school is able to provide. So sometimes that decision about should they be in and out. And the way it works in schools is that you have the general education setting, and then you have what are called push-in services. So if a child with an intellectual disability is in a general education classroom, they will often have what are called push-in services. They will not be following the exact curriculum that the rest of the students in the classroom are following. They'll have a modified curriculum, which could be modified from the number of answers to do, to the specific subject matter within the classroom. Beyond that, whether it's intellectual disability, I'm just using that example, or other needs, a child may be pulled out of the classroom to go into a smaller group for one class a day to receive additional instruction. So someone with speech and language might go out and receive speech services, or someone who needs reading support may go out and receive additional reading support out of the classroom. So those are both push in and push out services. So some children, whether they have an intellectual disability or they have ADHD, or even if they have nothing at all, they don't like to feel behind in the classroom. They don't like to feel like they're not following the material. So a lot of this has to do also with personality. Some children are aware of their limitations and they don't really, and they get along with their peers, they feel integrated, they know it's modified and they're comfortable with that. And then other kids really don't like that and really hate that and really hate feeling singled out. And some of that has to do with how the relationships are built within the classroom, and some of that has to do with the child's personality. So sometimes it's not so much what a child needs, but it's also how the child feels about what they need in terms of providing these services. But in a good world, when things are working well, a child, whether it's an intellectual disability or autism, will be in that classroom with their peers and do everything else their peers are doing, but the modifications are academic. They'll go to the cafeteria, they'll go to recess, they'll go to the same classes. And then a less restrictive environment would be, a more restrictive environment would be a child to get pulled out more frequently, or to go what's called into a self-contained classroom. Well, they'll receive services within that particular classroom and just that classroom. Sometimes it's just that classroom all day. So there are classrooms in some districts that are for kids with autism. They'll be in that classroom all day. Other kinds of environments are you're in the classroom, but you can go into the mainstream, it's called, to take other classes or for specials. So you might be in the academic classes just in this one classroom, but then go to gym with other kids or music with other kids. Those are called the specials in terms of the lingo classes. And then the most restrictive setting would be a kid who goes to another school entirely. So a school dedicated to servicing kids who might have certain needs that are hard to manage in the school, like I just mentioned. I mean, they're even more restrictive. So a residential placement's even more restrictive. And then where you go to a school where you live there. And then the most restrictive is considered actually homebound instruction. So parents can choose to homeschool their kids, but if a child is missing school because of medical needs, they'll often receive temporary homebound instruction. So let's say I'm out of school for a couple of hours. Let's say I have a surgery, and so I need to be out of my school for a certain amount of time recuperating. The school can provide what's called homebound instruction, and that's like depends on the amount of hours, but it's like, let's say 2 hours a day, 5 days a week of basic instruction in terms of the academics. That's the most restrictive type of education. So some kids with intellectual or autism, usually it's not that. It's usually kids with, let's say, certain degrees of emotional disturbance, and they can't be in the classroom. They might offer that temporarily while coming up with a plan, but that's considered the most restrictive. So that's the school. So I just want to emphasize the importance of the school, obviously, in all of this. And then in the community environment, there are a range of services that are available, from individual parent management treatment, guidance treatment, family treatments, in-home services. So there are a range of services. For autism, applied behavioral analysis, which is a form of therapy, is available through mandated law that families receive those services if their child's identified with autism. Autism often includes intellectual disability, but that's a disability in which you can receive services in the home. Again, accessing those can be sometimes not timely and a bit problematic, but that's certainly a big piece of it. And I list some other services. There are private residential services in the community, wilderness programs. Usually those are for kids with more emotional challenges, behavioral challenges, rather than autism or an intellectual disability, I'd say. Let me just keep an eye on the time. So just going back, yeah, that's actually my last slide. So just was going to talk about the future. So I think we can kind of stick with this for a little bit longer. But essentially, in terms of just working with kids, Alexander, should I wait for questions, or are there any intermediate questions? I don't know if you're looking at the chat or if there are questions.
If anybody has questions, feel free to ask them as you go.
Okay. All right, then I'll keep moving right along. So in terms of getting back to the diagnosis of just a couple things I just wanted to point out in terms of the diagnosis. I think in terms of the main developmental disabilities that we experience. So there's the situation where someone is discovered very early on, either in utero it's suspected or examined for, or very soon after birth, when a child has very specific kind of needs that are very noticeable, or syndromes that are known and noticeable, Down syndrome or things maybe of that nature. So very early on, I think that kind of will send you on a slightly different trajectory, where usually you'll be embedded within sort of a medical system. I think from a psychiatric perspective, there are a couple of issues. One is that the under recognition of essentially diagnostic concerns in folks with intellectual disability, or a misattribution of emotional behavioral needs to the intellectual disability. So the underdiagnosis of depression, the underdiagnosis and treatment of depression, or underdiagnosis and treatment of anxiety, or underdiagnosis and treatment of some mood instability, whether I'm not thinking so much frank bipolar disorder, or I think you could even say the underdiagnosis and treatment of psychosis. Although there, I think that will be more apparent if it's a big concern. So I think in terms of the field of psychiatry, one issue is the underdiagnosis and underrecognition of these issues. I think the other one is in terms of the mental health components in treatment. Relatedly, there's a dearth of clinicians who are comfortable in both worlds. I think in Connecticut, we had many of the child clinics expect you to have therapy to obtain meds. We very rarely prescribe we don't prescribe in our clinic medications without therapy. Now, what we do for kids who are stable, have had therapy, have had parent work, we will put them in what's called our long-term care clinic, which is the same clinic, but we'll see them once a month and just, touch base, or once a month to 2 to 3, touch base and continue medications. They're stable, but medications have proved to be helpful, so we'll continue. But most clinics expect treatment, therapy to occur in order to have meds. And some kids just don't have the skill set or intellectual capacity, speech and language capacity, to have an individual therapy or therapy. So those kids are often undertreated, and it can be hard to find services for those kids. Both private practitioners or folks that are, paneled with certain insurances. So that is, I think, an issue. Another issue that we see is in the case of the autism, is the underdiagnosis of autism, I think, in people of color. And I think there's 2 layers to that, probably. Many clinicians are white. I don't want to say, yeah, I mean, obviously most clinicians are white. Many clinicians are white, and sort of, I think when you have very clear signs of autism, I think that's more straightforward. And the way you diagnose with autism are with these with observable instruments. So there's a whole range of instruments to diagnose autism, and the majority of autism is paired with intellectual disability. You have certain evidence-based instruments that are observational. And I think kids with clear autism are, quote, easier to figure out and see. But then there's kids who are on the other side of the spectrum, who are, let's say, have more verbal abilities, social function, but as they get older, their social function is clearly not on par with their peers, and their features of autism become more apparent. Sometimes students of color will have misbehaviors attributed to them to misbehavior rather than autism or another, or trauma. I mean, it's not just autism, it's trauma. So kids with trauma will often act out, and kids of color will often have their sort of traumatic reactions, kind of misattributed as just they're behaving bad, they're misbehaving. And I don't think it's mostly, to me, it's largely unconscious process, which doesn't make it any better, but I think that's part of it. I think when if you're white culture, then you also, white culture has certain features that are very, all cultures have certain features. And so what are the nuances that, quote, deviate from that culture, are easier to pick up if you're a white clinician with someone with autism who's white. You can kind of, maybe have a better sense of where things are deviating in a subtle way. And those misattributions with other cultures, whether they're white or Black, and it, happens cross-culturally. So, Black physicians would then misattribute sometimes for other cultures. So it's just, so it is an issue to think about. But I think those are more the nuanced, not always nuanced, but there's lots of data that schizophrenia is kind of overly diagnosed in Black individuals, and mania less so compared to the same, white samples. Those are all the things that we have to always think about. So it's just pointing out some of the areas that we have a bit of trouble with getting it right sometimes. Where the diagnoses are more clear cut, then I think we have less of that built-in bias that affects it. But areas where more subtle, then we have a harder time that way. So getting back to the diagnostic piece, so we have those issues, and then over time, as has happened, is that there are more and more discoveries of genetic elements that contribute to a diagnosis of either autism or intellectual disability. Usually intellectual disability, the milder forms of intellectual disability often have an unknown genetic cause. The more severe forms will have more associations with genetic explanations. I think these are always difficult issues. I think a lot of, so the guidelines for I think neurologists, geneticists, is that if a person is diagnosed with autism, they should have I think neurologists say they should have a genetic screening and an MRI. I don't necessarily find that particularly useful, especially with folks who have level 1 autism. So autism is diagnosed in terms of severity by level 1, level 2, level 3, level 3 being the most supports needed. And that would often be associated, and autism diagnosis is associated with intellectual disability or without intellectual disability. So it can become useful to understand what's driving things. It can be useful for family planning, but it's not so useful in terms of direct care, direct treatment. And it can be a mixed finding. So sometimes, contrary to counterintuitively, if someone you'd think that if someone has a genetic finding that people would be more empathic and more sympathetic to that person, but in fact it's often the opposite. People are less sympathetic because they view it as more ingrained, like more like, well, they just have that problem. So it's a delicate matter of in terms of the genetic testing and how useful it is to the family. But certainly there's a lot of work in this area, and interventions can be done in certain conditions, and where you can do interventions that are going to have a person be, more adaptive socially, functionally. That's generally a good thing. So that's a part of it. So then, in terms of, well, what do we do when there is a treatment need for kids? One of the nice things about working with kids, I find, is that kids are still kids no matter what. Like, I'll give you an example. Once when I was in adult psychiatry, this guy would come in super manic, but also had personality type stuff. And he was like 6'6", was very well built, and he had HIV. And he would come in and he would slit his wrist and say, come try to take me down. And it was a very frightening experience for everyone. So that's kind of an example of a frightening experience. And then with kids, I think the kinds of experiences that are difficult. I mean, I've had kids that try to bite you, kicked you. I've had a shoe thrown in my face. So kids can be, can have a hard time too. But I remember, one kid I was working with, he ran out of my office. He ran out of my office. He went outside, and I kind of just chased him without trying to be too chasey looking in terms of getting him too excited about the chase. So I followed him, and he was outside, and he decided to get the garden hose and stick it through one of the windows. And he turned on, and he said, I'm turning the water on. He had the water on. And when I got closer to him, he'd put it through the window. And then when I backed off, he would leave it out the window. So just this game of like, if I got closer, he'd put this water in the window. And, it was like, I didn't want that office to flood. It wasn't, my personal office. I wasn't too worried about it, but it just gives you, was very humorous experience. And in the end, and that's what I think kids can still laugh, have joy, are fun, even with their tremendous difficulties and really horrendous traumas, horrendous experiences. Kids are still very fun to be around and be with, and have a certain joie de vivre, which is really a pleasure. So the point being, oh, is that your stuff or my stuff? My computer. Well, I'm not sharing, so it's okay. So the point being is that generally the treatments for kids with intellectual disability, with autism, will largely remain the same. And if the issue, again, they're not the same in terms of degree of severity and the kinds of services they need, but they remain the same in that you are trying to enhance someone's social engagement, behavioral regulation, as the two main things, and their mood, right? We basically want to be reasonably happy in life. We want to be able to regulate our mood and not be like bouncing all around with anger or excessiveness, and to get along reasonably well with others. And regardless of your level of disability, we can always move forward in that direction. And the beauty of working with kids is that development is not static, and you can get kids on a better trajectory than they could otherwise be. So Sometimes the level of capacity that a kid has will also depend on their family environment and their social environment and how much they receive in terms of supports from others. At a time that can be very challenging for families to get the support and receive the support. But when it works well, then it's a really lovely thing to see. So for example, in our program, which does have some limitations, we have kids that have an intellectual needs, and we'll try to pair them with the right group according to their intellectual ability. But we're still, some kids can't read and write, and our program involves some writing of your feelings, for example, or strategies. Well, we work with those kids to be able to communicate that in a way that doesn't embarrass them that they can't read or write, but ultimately try to create a supportive environment so that their concerns can come to the fore and can come to the front, and we can have a discussion about helping them, where they can develop their own skills for functioning in terms of that psychiatric comorbidity that occurs for them. So I think that's a big piece of it. The other one is that kids with who might atypically relate, whether it's usually it's with autism, but also sometimes with intellectual disability, or ADHD, where the kids might not get along as well with others. Group environment like our day hospital allows kids to feel connected and bonded with others, which then markedly improves their self-esteem. And when their self-esteem is up, then they're less irritable, they act out less, they're no longer that child with the behavior problem in the classroom. So that can be very, very powerful as well. Let me just keep an eye on the time. For the other piece about the treatment that I'll add is that schools offer for kids that are struggling socially. Schools will often offer a lunch bunch to have kids experience getting along with others and how to communicate with others and learn social skills. And so those would be kids that either have trouble with that, whether it's kids with ADHD, kids with emotional dysregulation, kids with autism, kids with some intellectual difficulties. So in terms of the future, I think the main things to communicate is that there continues to be an evolution of genetic findings and genetic determinants for certain conditions. Obviously, we're in a multiplex world where usually it's a combination of factors, and I don't think it's very rarely the holy grail, but certainly more awareness, more determination, more ways determining of background findings in order to make changes and improving kids' well-being from a medical genetic perspective is certainly there. But in terms of the rest of the future, it's really kind of a constant struggle of advocacy. Clearly, kids with disabilities are much better served in schools than they were 40 years ago, 30 years ago. There's more acceptance of folks rather than shutting them out into a different world. But there remains a very long way to go in terms of providing families with the level of supports that they need. In particular, the more severe the challenges are intellectually, along with behavioral emotional needs, the degree of severity together or their interface, it can be very hard to find the right supports and services for families. So that continues to be an ongoing concern. And I'll leave it at that. I think I'll leave it at that, and I'll answer any questions if you have any about this topic or life topics. If you want to ask about life topics.
Thank you so much for that talk. I had a quick question. Earlier, you had mentioned that for patients who have intellectual
I think
disabilities.
you're talking, but I can't hear you.
Oh, I'm sorry. Can you hear me? No? You can hear me? Okay, perfect. Can you hear me?
Am I the only one that can't hear you?
I can also write it in the chat if someone else wants to. Can you hear me still? No?
I just see everyone. I don't see you muted, but I can't hear you for some reason.
Maybe your computer audio is low.
Okay.
I'm going to disconnect myself and see what happens.
I can also just write it in the chat to make it easier.
Okay, I can hear you.
Reading it.
I'm here.
I think you can hear you now, Linda.
Oh, okay, thank you.
Sorry
What
about
I was asking, yeah, what I was asking is, you had said that patients with intellectual disabilities, sometimes everything is kind of ascribed to that disability, and maybe, you know, if they have depression or other, you know, needs going on, that's not necessarily looked at as in depth. So we had a talk from a family prior to this who had shared their challenges with navigating the healthcare system and having children with intellectual disabilities. I was just curious, as a physician and future physicians, what would you encourage us to do so that we don't necessarily miss that, or, you know, kind of get this diagnosis and put every global complaint under that, basically?
Yeah, that's a great question. I think the main thing is, you know, don't forget your SIGI caps, which is, you know, in terms of, yes, I think I think there's two parts to that, the misattribution. One is the tendency to discount the other, right? It's sort of the subtle aspects of the subtle thoughts that creep it, that someone is not as deserving or not as, you know, and I think these are very unconscious, and I don't think most of us would admit that to ourselves, but the unconscious biases that occur, that someone is not as deserving of thinking things through, or it's just the way they are, you know, it's just the way they are. So I think always guarding against that, and thinking to oneself, and it doesn't have to be said in a pejorative way. It's like, well, of course they're feeling that way because they're, you know, they have this disability and life is hard. So of course they feel this way. You know, it's a little like akin to a widower who lost his wife. Well, widowers lose their wives, and at times it's very sad and there's a lot of bereavement, but at times it goes into depression. You can't over pathologize and say, well, oh, their wife is dead, so now they're, you know, they must be very depressed, and they're depressed, and they're, you know, but other times it's like minimizing the depression. So I don't think it's different than that a lot of times. Sometimes it's effort and energy, because folks with disabilities sometimes require more patience and more time to get through things. So sometimes we feel pressed for time and maybe not give someone as much time of day because of that. So I think there's these subtle things that are built in that are not truly, you know, evil, but in the end, we have just to guard against. So I think if a kid, I think it's one is to just answer your question directly too. It's like, yeah, don't forget your SIGI caps, and just be careful to not misattribute the reasons for it, or at least think through, okay, well, this happened and their intellectual disability is kind of putting in this position of peers making fun of them and they're depressed. But is that an adjustment temporary, or is it really just now have sent them through a real bona fide depression? And then how can we ameliorate that? Is that through therapy? Is that through getting them in a group? Is it that through medication? That's how I think of all of that. And I think that all the time, for all people that are not like me, as much as I can, you know, sort of, I have you know, sort of an angry white family demanding certain things on the inpatient unit, that's well-to-do. You know, I'm always trying to think, all right, are we going to accommodate them more than a family from the inner city who might be expressing their frustration and anger and worry about their child in that feels differently? And are we more comfortable with maybe not acceding to their wishes? You know, I think it's just a thing that we constantly have to ask ourselves when we're working with people that are not part of our community, essentially. So it's just very much just a food for thought for all situations.
Thank you so much.
And, you know, I know I'm not perfect with any of this stuff. I just think it's important to keep it in the forefront. You know, having these conversations actually helps me to remember to, like, yeah, I have biases and I have to constantly see where these might land.
Any other questions before we wrap up?
I have a quick question. Sorry, I have a quick question about when you were talking about the school-based services, in terms of the therapeutic schools. what type of services do they offer that help a child with intellectual disabilities? Do they have things like art therapy or individual therapy for them to kind of help get through the material at their particular pace?
Yeah, yeah, they really range. So one of the schools I consult with, I don't consult with they have a therapeutic behavioral school, which is really kids that struggle to manage their emotions and behaviors that usually don't have intellectual disabilities, although they can be, borderline intellectual functioning sometimes. But then there's another school, it's called ACEs Village, which is kids that have more profound needs. And that can range from, kids in like, wheelchairs, like that basically have very little motor function. And so those would be really maximizing activities of daily living. Or there's another school that specializes in kids with autism and intellectual disability. It will be, learning how to fold pants, learning how to iron pants. They actually have a mock store, and they teach the kids how to go into a store and like pick items off the shelves and go through the counter. So it can range from, just functioning in day-to-day life, learning how to brush your teeth. You get a reward for getting your hand near the toothbrush. Then it's called chaining. Then you get a reward for picking it up. Then you get a reward for putting it near your mouth. And so so it can really vary. But for intellectual disability, they could have an art. There's no reason not to have an art program for kids if they can hold a pencil and draw and they're interested in that. So it tries to be programmatic, but then individual needs are really catered to. That's actually a real requirement in special education law. You have to cater to the individual child's needs. So when you develop what's called an individual education plan, you actually have goals for that child. Speech goals, language goals, emotional goal. I mean, you don't have to have goals for all of those if they don't need those, but you have a need in an area, then goals are established and mechanisms to achieve that goal are put in place. So it might be, for activities of daily living, we'll learn how to fold, clothes and, what it could be an objective, it wouldn't be quite phrased that way, but just to give you an idea.
Thank you.
So I'm so sorry. For the sake of time, we're going to have to move to the residency panel to respect everybody, all the residents that have signed in. Dr. Ponson, thank you so much for joining us today. Would you be able to share your contact information for anyone who might have questions following the session?
Yeah, that's great. You think you have my email, so
yes,
there. That would be
I can
great.
put your email in the chat.
Yeah.
Okay, thank you so much.
All right, thank you for putting this together. I really appreciate it. You take care. Bye, everyone.
All right, thank you.